Happy St. Patrick's Day, everybody. This is Rush University Medical Center Division of Nephrology Renal Biopsy Conference for March 17th, 2022. Today's CMA activity code is 485041. We've got a great case today by Dr. Whittier. This is being recorded and it'll be uploaded on our YouTube channel. All recordings are done by Dr. Baxi. Please subscribe to our YouTube channel. And if you know anybody that's not on the mailing list, or if you're not on the mailing list, just let us know and we'll send you alerts every week when we're on. Everyone's muted except the faculty. Put your comments in the chat box. We have nothing to disclose. And to ensure patient privacy is preserved, all identifying information, including age, gender, ethnicity, dates, exact laboratory values, and/or other details have been changed to disguise the identity of the patient and to protect patient anonymity. We have to change that word because I can't pronounce it. I think we're ready for the case. Bill, you want to walk us through?
Sure, thanks. It's like in Finding Nemo, where there's that little fish that can't say anemone. He's like anemone. It's cute. Okay, yeah. So today we've got this interesting case with progressive leg swelling and acute kidney injury. He really only had a past medical history of diabetes, but his real significant medical history was significant for this metastatic squamous cell carcinoma of his larynx. And over the last 2 years, it's been treated with varying agents and surgery and radiation. So it was initially diagnosed 2 years prior to the admission at Rush as stage 3 with 2 lymph nodes spread. He received local radiation therapy and carbo and had local regional recurrence and lung mets later on. So then at that stage, he was given the checkpoint inhibitor nivolumab and also paclitaxel and cetuximab. And he also had surgical resection with a tracheostomy 3 months prior to that admission. So he was given that 4 months prior to our admission, and then he had this surgical resection about 3 months prior to admission. So during the 3 months prior to admission surgery with the tracheostomy, he actually developed AKI, which was thought to be due to ATN. He was oliguric. His creatinine went up to 3 from the baseline of 0.7, and he recovered. Made urine again, did not need dialysis, and then on post-op day 3, he was discharged with a creatinine of 1.6, so he did okay. 1 month later, though, he came to the outside hospital again with what seemed to be a recurrent or a pneumonia. He had fever, cough, green sputum, and his creatinine on admission for the pneumonia admission was 1.4, but it's kept going up despite giving antibiotics and IV fluids. His urinalysis at the time had 20 white cells. It was an active urine with quite a bit of proteinuria. His urine PC ratio was around 7 grams per gram. So he's actually, secondary serologic workup was done, which was negative, and that's below. And he was treated empirically with pulse methylprednisolone for suspected GN. He actually underwent a renal biopsy at the outside hospital, but unfortunately, they really didn't get any sample. They had 5 glomeruli on light, and they were all globally sclerotic. There was no hint of any kind of a diagnosis there. There were no crescents or anything like that. He was given the steroids. He was discharged on prednisone 60 a day and Augmentin for his pneumonia. His creatinine had peaked up at 4, but had come back down to 2.5 on the day of discharge. So they didn't really know what they were treating, but they were giving him some steroids, and it seemed to have worked a little bit. So he didn't actually follow up with nephrology. Unfortunately, he stopped his prednisone after 2 weeks. I think he had some issues with depression, and his cancer had really been affecting his life, obviously. So 2 months later, he came back to the oncology clinic, and then he was immediately admitted because his creatinine was 4.5 and his K was 5.8, and he had significant azotemia. He didn't really have any complaints at that time, except for the leg swelling. So before all of this, 5 months prior to admission, his creatinine was normal. He had a completely normal UA. Okay, so his past medical history is really significant only for the cancer, and his surgical is related to the cancer. No social, family allergies or review of systems that was really important. Medications, he was on the medications as above for this chemo and immune therapy, and he was also on pain medications and sleep medications. He did not take any NSAIDs or herbal medications. On exam, he was normotensive. He had typical head and neck changes from his surgery. He had a tracheostomy, he had a PEG, and he had 1+ edema. So his outside labs for the serologic workup that was 2 months prior to admission when he came in for his pneumonia, and they noticed his urine was active. That's where his creatinine got up to 4. His complements were normal: GBM, MPO, PR3, all negative. ANA was negative. Hepatitis and HIV were negative as well. His rheumatoid factor was also less than 10. He had an SPEP, UPEP, and serum free light, which was also unremarkable. And that point was the first time his urinalysis had 4+ protein and was active with also 7 grams per gram. And then that's when he had left on the prednisone and then didn't take it. And so when he came back to the oncology clinic, he then got admitted to Rush. And that's where the labs are there. The admission labs to Rush were BUN of 125 and creatinine of 4.5. His albumin was 2.4. LFTs were unremarkable. He was severely anemic, and they had been dealing with that with transfusions, whereas hemoglobin was 6.4. He did have a few schistocytes, but his haptoglobin was not low. And his urinalysis at the admission to our hospital showed 4+ protein, active urine again. His AC was 5 grams and his PC was 11 grams. His ultrasound was pretty unremarkable. So we did a second renal biopsy, hoping that we were going to get enough tissue this time.
Great. Any questions? Well, that's a first. Casey, you want to tell us your thoughts on this case?
Yeah, I'm kind of dizzy right now. There's so much going on. This guy seems like he keeps coming in and out with AKIs, dating back a few months. He's got a very complex past history of this head and neck malignancy that's been treated with a few different courses of chemotherapy. One of them includes a platinum-based therapy with carboplatinum, and then some immunotherapy with nivolumab and EGFR with cetuximab and all these sort of nephrotoxic drugs. And this recent admission, it seems like he's a really sick person that comes in with AKI. Well, actually was sent to the oncology clinic, from oncology clinic with AKI. So differential diagnosis, obviously, but based on the urinalysis being so active, we suspect the glomerulonephritis with lots of blood, 3+ blood, 180 RBCs, and some pyuria. He also has a significant amount of proteinuria, and it seems like it's about 50% or so albumin. So it seems to be glomerular in nature. So if he's got glomerular proteinuria and active cytomen, this is a GN until proven otherwise. Unfortunately, he had a previous biopsy that wasn't really that revealing. It did show there were some scarred glomeruli. 5 of the gloms were globally sclerotic, and unfortunately nothing on IF. So I suspect this guy probably does have a pretty significant amount of background damage to his kidneys. And so what's the cause of the acute is kind of what the question is. So if interstitial nephritis wasn't seen on the previous biopsy, and he was on and off steroids, and the nivolumab was given 3 months ago, although it's one of the things about these immunotherapies is that you can develop interstitial nephritis weeks to months after discontinuation of those drugs. So I suppose he could have interstitial nephritis, but that's not going to be my top because of the how proteinuric and nephritic he is. So so the other things that could happen here could be the cause of AKI, could be a GN. ANCA is negative. ANCA is negative, so it could be an ANCA negative or a sort of a immune-mediated glomerulonephritis. We see that sometimes with just malignancy, head and neck cancer. He could have, his complements are normal. I was thinking every time I see a lot of nephrotic, nephritic, MPGN, part of the differential, that also seems with a normal complement, less likely, but carboplatinum can give you tubular interstitial, like especially like ATN, and raise the creatinine. That's usually more of a CKD as opposed to this degree of AKI. So I think I'm sort of narrowing this down into this is an RPGN in somebody who was previously treated with monotherapy with steroids. And now he stopped taking the steroids and he kind of relapsed through it. So I'm going to go with like a necrotizing, probably even crescentic, given the degree of renal failure, glomerulonephritis. And then we're going to have to figure out, is this directly due to the cancer? Is there some other underlying process going on? None of the serologies seem to be very helpful because they're all negative or normal. And SPEP and UPEP are negative as well. So if we see a glomerulonephritis, is this related to the malignancy, or is this just kind of de novo? Is going to be a little difficult to tease out. There doesn't seem to be any hemolytic process, no diffuse cystitis, platelets seem okay, they're 250. Hapto is elevated, if anything. So there's not really like a clinical diagnosis that I can give her, but I think we're probably going to see a necrotizing GN on histology.
So do you have any idea? I know most of the renal autoimmune effects of checkpoint inhibitors are interstitial nephritis, but there's been various case reports of GN and whatever. Do you have any ideas that 95% interstitial nephritis and a sprinkling here and there of a GN?
Yes, it's most of the side effects of immunotherapy, like the checkpoint inhibitors, is tubular interstitial stuff. ATN interstitial nephritis is over 90%, and then there are some cases of necrotizing GN with checkpoint inhibitors. So yeah, it's less than 5% of those cases would be a GN. And
it's pretty much felt, or that it is the checkpoint inhibitor that's the cause of
immune activation. Yeah.
Yeah. Well, you brought up an interesting point when you were discussing the fact that some malignancies do have glomerulonephritis associated with them, and it's pretty unusual. But you wonder why that is, and if there is a slight tendency for that. Maybe it's some antigen that gets released and sets up an immune reaction that reacts with the glomerulus. Who knows? Similar to membranous or something. But who knows? But you wonder if that's the case. If malignancies have a slight tendency for a some antigenic related GN, that then the checkpoint inhibitor might just help bring it out. It's not just a brand new. I think you alluded to this. A brand new de novo GN. Or is it somehow related to malignancy? There's no answer to that, but if you have any thoughts, I'd be interested to hear them.
And no, I mean, like, for example, membranous, which is associated with malignancies, I didn't really bring that up because this patient has just such a RPGN and so much hematuria that I'm not really even, unless there's crescentic membranous, which is, I guess it could happen. So that we see with malignancy. So there is definitely some cross reactivity with the antigens from the malignant cells and the kidney, sort of a PLA2R negative for the most part in malignancy. So yeah, I don't really know what the mechanism of a malignancy, like a head and neck malignancy causing a proliferative GN. I don't know what the antigen would be.
Dr. Glassick, what are your thoughts on this case? You're muted, Dick.
Yeah, Roger, I'm sorry, I was muted. I think I would agree that this certainly falls into the general category of RPGN, and it's rather disappointing that the initial biopsy wasn't revealing. I wonder whether IgA dominant infection-related GN should be considered because of the onset in connection with a pneumonia.
Yeah, so that's an interesting thought. His complements were
normal.
Yeah. So, but that doesn't rule that out by any means.
And often that is staph, and they did not bronch him. So we don't have a culture of his pneumonia. His pneumonia was a clinical diagnosis only, so it could have been a staph pneumonia.
He's gotten cisplatin, which is, even we see a lot of nephrotoxicity with that. It doesn't fit this picture, but it certainly doesn't help to have another renal, lesion on top of it. What I don't know is, everybody gets this platinum. If they were all biopsied, if you'd find some interstitial disease in everybody, you know, we only see the ones whose creatinine go up significantly, but it's a pretty potent nephrotoxin. So he's had some pretty bad insults here. And cetuximab, I now know, because Dr. Gashti told me the other day, causes hypomagnesemia. Just to be complete in the onconephrology department. We don't have a magnesium on him, do we?
We don't.
Okay, just throwing that out there for fun. Anybody else have any comments, or we'll get to the wheel?
Yeah, Roger Mario. I just want to point out that the group here at MD Anderson, Houston, where you get the best food in the US, by the way, had published their series on glomerular diseases associated with checkpoint inhibitors. This has been echoed, a report from the Brigham, Mass General, and Yale, and that was, as it was pointed out, there are several out there. But it's not just the necrotizing GN, also cases of minimal change, FSGS, and membranous have been reported. The other thing of interest for the audience is to reinforce the fact that interstitial nephritis due to these drugs usually has an underlying intake of PPIs. The relationship is unclear, but it's there. That's all.
Thank you. Thank you. By the way, for those that didn't understand his culinary comment, I was somebody in the chat board said greetings from New Orleans, and I said NOLA, best food in America. So I think that's where that came from. I would still hold that New Orleans has the best food in America. So I'm not wavering on that. Let's see who the wheel picks here. Kelly.
All right, give me a second here, Kelly.
Kelly read last week. She was a superstar. Pressure's on. Will she be able to have a repeat performance?
Kelly, you can unmute yourself, and then I will share the screen.
Can you hear me?
Yep.
Okay. Perfect.
And I will, give me a second here.
Kelly is one of our first-year fellows.
Click on the screen.
Okay.
Yep, you're controlling, and I'll let you advance the slides.
All right. All right. So here we have one core. This is the trichrome stain. Here we're looking for blue staining material, which would be indicative of kind of chronic scarring. Here I see that overall this is a pretty good sample. I do see glomeruli kind of scattered throughout. Here's one that I think is almost scarred over, but in between the glomeruli, we have the tubules, which appear to be spaced out with a lot of blue staining material in between them. So I do see quite a bit of scarring. God, I would say like almost like 80-90% scar.
Yeah, it does look pretty extensive. Some of this is edema mixed in there. So I have to correlate with the PAS stain that shows whether the tubules are truly atrophic. But yeah, it was overall about 50%. So pretty diffuse.
Okay, I always overestimate. All right. All right, so here we're moving on to the PAS stain. We have one glomerulus in the center. So looking at the capillary loops, they do appear open. We have Bowman's space and then Bowman's capsule, which does appear to be intact. We have the hilum here, afferent and efferent arterial. This one actually appears pretty healthy to me. The tubules surrounding this glomerulus kind of maybe look a little bit unhealthy. I don't clearly see a brush border. let's see.
Yeah, so ATN there,
Yeah.
thinning of epithelium and loss of brush border.
Okay. And then what did you, Dr. Simbulik, did you say that this glomerulus looked pretty healthy to
Yeah,
you?
yeah, I
Okay.
agree with you. Yep.
Okay. Okay, and now we're still on the PAS stain. We have one glomerulus in the center here. This glomerulus does not look healthy. So kind of to get oriented, here we have the hilum here. The capillary loops over here do appear open. And then we have this big crescent with more than 3 layers of parietal cells present that are kind of caving in on these capillary loops here. And then surrounding this glomerulus, obviously we see all these tubules, which definitely do not look healthy, loss of brush border, and we see some even sloughing as well.
Yeah, good. Nice cellular crescent. And then in the top right, some of those tubules are becoming atrophic. You could see how they have thickened basement membranes
Oh,
and
yeah.
shriveled and shrunken down. Yeah.
Yeah. Okay, so here we have an H&E stain with one, so this I think is a glomerulus in the center here. So this glomerulus does not appear healthy. I think, I'm trying to see, so I think that this is, would be considered a crescent here. I'm trying to look for any like fibrinoid necrosis.
Yeah, you're on the right track. It's a necrotizing lesion. You could see a little chirectic debris there. Yeah, some black dots, nuclei breaking apart, and it's kind of starting to transition to a scar. That's why the fibrin is kind of not as bright as we typically see in a real active lesion. But yeah, it is a segmental necrotizing lesion, like you said.
Okay. Okay, so we're still on the H&E stain. We have another glomerulus here. So just really hypercellular. And then I think also I'm seeing, is this chirectic debris here or?
Yeah, Kelly. And just to the left of the arrow is a little fibrinoid necrosis.
Just to the left of the arrow. Okay.
Yeah, so kind of just if you circle that area, it's a necrotic area. There's a lot of proliferation of cells. And then at the bottom, you even have red cells breaking out into the urinary space.
Okay, yeah. Okay, so we're going back to the PAS stain. One glomerulus in the center. And here again, we're kind of seeing a break actually in Bowman's capsule, and then a crescent here. The capillary loops are still open over here. The hilum's over here. And then again, we're just seeing ATN in the tubules.
Yep. Yeah, and some tubules are atrophic, and then there's some fibrosis settling in the interstitium as well.
Yeah, okay.
Yeah, so 4 out of 12 glomeruli had these necrotizing lesions and crescents. So a third.
Okay, so this is the silver stain or the Jones stain. So here we're mainly focusing on evaluating the basement membrane, but I assume that this is a crescent over here again that we're seeing. The Bowman's capsule.
Yeah, so look at the basement membrane. Do you see, what are we looking for?
So usually we're looking for spikes or holes or breaks in the basement membrane. So is this kind of broken here?
Yeah, you
Okay,
have fragments of basement membrane there. And then back where you were over by 7 o'clock in the very bottom, yeah, you could see basement membrane there fragmented,
oh, yeah.
broken apart. Yeah, and parietal epithelium surrounding it. Yeah, highlighting the vasculitic nature of these lesions.
Might be just a little lag here.
Okay. So back to the PAS stain. Here we're just seeing more tubules that are undergoing ATN or that are atrophic with the thickened basement membrane. And then the interstitial kind of some interstitial infiltration here.
Yeah, lots of brush border, thinning of epithelium, ATN. And then, yeah, a little bit of a sprinkling of lymphocytes here. And then in some areas on the next slide, it becomes more dense. If you want to go.
Oh,
Yeah, I
yeah.
also thought there was a component of an interstitial nephritis here. There's no glomerulus there. You know, it's not associated with the necrotizing lesion. This was kind of out in the interstitium.
Yeah.
What kind of cells do you see mostly there?
I see mostly lymphocytes.
Yeah.
Yep. Yeah. And then just like you said, more sloughing.
Yeah.
Or I guess that we can't really tell because this is H&E, right?
Yeah.
Or,
It does look thinned out. Yeah.
thinned out. Okay.
Yeah.
Okay. Moving on to immunofluorescence, IgG negative.
Yep. Yeah. Everything else was negative.
Everything else is negative. Okay. Okay. So moving on to EM. So to orient myself, we have the capillary loop here, basement membrane, and then kind of urinary space here, and then mesangium here and here. So looking at the basement membrane, I actually don't see any deposits within the membrane itself. And I don't necessarily see electron dense deposits in the mesangium either. The podocytes, I'm sure we'll get a closer view, but they look pretty thinned out as well, or flat. I guess there's some that aren't as flat here.
Yeah. Overall, it looks diffuse effacement as more look kind of flattened in the face, as you pointed out. Yeah. Okay. Yeah, I agree with you. No deposits.
Okay. Okay, so this is another capillary loop here, basement membrane. We see the flattened podocytes again, and then here we have the urinary space. Again, I don't see any deposits within the mesangium or the basement membrane. And the actual thickness of the basement membrane doesn't appear like thickened at all. It looks pretty normal.
Yep, I agree with everything you said. There we got a measurement.
Okay, so 352 nanometers is normal thickness.
Yep.
And here it's just re-demonstrating the diffuse foot process effacement.
Yep.
Okay. Okay. So 4 out of the 12 glomeruli had crescents. So I would call it crescentic glomerulonephritis. Immunofluorescence was negative, so it's posse immune. There was some interstitial nephritis, and then diffuse foot process effacement. So like with a podocytopathy, I guess.
Yeah, the podocytopathy, that might just be secondary to all the necrosis and inflammation in the glomeruli. Yeah, but you're right, that there is a podocytopathy as we saw. And yeah, nice read, Kelly.
Thank
Yeah,
you.
great job as usual.
We don't often see diffuse foot process effacement with post-immune necrotizing vasculitis, do we? I mean, I'm sure it can be, but is it usually not there?
Not this diffuse. Yeah, usually, like you said, it's more focal or partial. Yeah.
And it brings up a good point because I know Bill's written a lot about this with lupus and kind of correlated the podocyte degree of podocyte effacement with the degree of proteinuria, and implying all along that this may be a separate lesion. And it may or may not be relevant to this case, but I was thinking the same thing. It just seemed like a lot of podocyte effacement for a vasculitis. And then I thought, well, it also has a lot of proteinuria, and we never know the chicken or the egg on that one. But it's funny Bill brought that up because it was, it's one of his things. And I like to point out now that the cat's out of the bag and we've seen the pathology, his background has now changed to crescentic GN.
Yeah, exactly. I wasn't going to do that before.
No, that would have been wrong. Or you could have fooled us and put minimal change or something up there, but IgA nephropathy.
Right.
Really nice read, Kelly. Really nice pathology. I got to tell you how much I love the silver stain when it shows pieces of basement membrane just floating in Bowman space. It says so much about what this lesion's all about, and it makes it so much understandable why you've got fibrin in there and why you'd have this reaction with the epithelial cell and having a crescent. Kate, the other thing that was interesting is there was a little bit of interstitial nephritis, and that being part of this checkpoint inhibitor, the primary lesion that we see with that. And it's hard to say. David did make the point he didn't think that was associated with a glomerulus, that it might be an independent process. Certainly wasn't the overlying pathology, but in the context of the case, I find it interesting and almost, I don't know, rewarding to see that. David, what percent of the interstitium was scarred?
Approximately 50%, I would say. It's kind of diffusely fibrotic, and like half the tubules looked atrophic.
And what percent of the total glomeruli were gone? It was 100%.
Well, we had 3 gloms. 12 gloms, 3 globally sclerosed, and then 4 with necrotizing lesions.
So a few that were not affected, in other words. Casey, any surprises?
Yeah, I mean, the whole case is kind of an interesting thing. It's not a surprise, but that we found. I mean, there's ATN. It's a really kind of a pretty significantly scarred kidney in the background, and then you get looks like a post-immune necrotizing glomerulonephritis. And I guess the challenge is to see if this is from some kind of an infection, like his pneumonia. Is this related to his head and neck cancer, which has been reported, or more rarely it could be due to the drug. I mean, the presence of the interstitial nephritis makes me think maybe it could be from the drug, because that is also present, but you could also have a little bit of interstitial nephritis that may be clinically insignificant from a checkpoint inhibitor, and your main lesion is from the other things. The head and neck cancer seems like it's in remission, but it's kind of come back. So I'm not really sure what the status of the cancer is, but you could actually have the cancer both in remission or active. I mean, I've read cases of active lung cancer causing glomerulonephritis, and I've seen cases of head and neck cancer in remission causing a glomerulonephritis. So the status of the cancer is probably less significant here, but I don't know how to tie this together, but I think the interstitial nephritis makes me want to push this a little bit towards more like the drug.
Yeah, I always wonder when people get chemotherapy, I know it's not directed the best thing for glomerulonephritis. It just seems hard for me to believe somebody getting chemotherapy that they're, that normal chemotherapy, not a checkpoint inhibitor chemotherapy, the normal chemotherapy that you could have an inflammatory disease. But that may be naive. It's also kind of hard for me to believe that it's not related. This guy's not doing well and he gets this drug and then his kidney just completely blows up. Do you think there's some salvageability here, Casey?
I mean, 50. I mean, so I don't know the creatinine. I mean, it seems like there's a lot of ATN, so that could recover. So I'm not sure if I would throw the towel in and not treat. I would still treat 50% interstitial fibrosis with some ATN there. I mean, keeping people off dialysis is always the goal here for me, because that has a whole different prognosis. So I would say I would treat. If that's your question, I would treat.
Dr.
Before
Corbett,
that,
would you-
what about, I'm sorry, real quick, Roger. He was also on a EGFR inhibitor, Casey.
Yeah.
What do you think about that? Could you figure out if we could tease out if it's EGFR inhibitor versus checkpoint inhibitor?
Based on histology, not really. And I'm not sure how I can say that it's, I mean, all of these are probably endothelial injury, but I don't know, like, if it's from, specifically from cetuximab, or if there's a malignancy induced, that part is probably more of a clinical correlation. I don't know if histologically you can tell.
Isn't that typically more of a TMA lesion though? Not a crescentic GN lesion or?
Yeah, it's been, there's tons of things that have been reported, but it's always really hard to tease these things out. The epidermal growth factor receptor inhibitors do end up impairing tyrosine kinase, and then that does lead to a TMA most often.
Dr. Corbett, would you treat this patient? I don't know if he's,
Oh, Steve, you're muted.
All right, David, what was the percent of sclerosis in the biopsy?
50%.
Was it 50? I thought it was more. I didn't know. So if it's
Of
50,
glomeruli or
the whole thing.
all right, so 12 on the light. If you include the fluorescence, there was 16. So 3 out of 16, including the fluorescence. Or
Had global sclerosis?
Yeah,
And then what percent had active lesions?
4 out of the 16 then.
And then how much interstitial fibrosis?
Approximately 50%.
Yeah. Yeah, I mean, I agree with Casey. I mean, I think you've got to give her the benefit of the doubt. She's got active lesions there involving about a quarter of the biopsy. I was trying to figure out where she would fall in the category of, the classification of vasculitic lesions. And she doesn't fall into the sclerotic because it's not more than 50% of the gloms being sclerosed. What percent were normal? I guess that would have been the better question.
Well, so the remaining 5 on the light, 5 out of 12.
5 out of 12. So it's almost 50%. Yeah, I mean, if you have 50% of the gloms that are otherwise normal, and then active lesions in the remaining, I think there's a good opportunity that this could at least respond to therapy. And so, yeah, I would treat. And I think that, as Casey said, the ATN may be a big component of the serum creatinine as well.
Typically, the AIN of checkpoint inhibitors is very easily and responds very quickly with steroids. This is a different lesion. Would you go with steroids alone, or would you give rituximab as well, Steve?
I would treat it like a vasculitis. I mean, I didn't appreciate how much active interstitial nephritis was there.
Very little.
Yeah, exactly. I mean, I would treat this like a vasculitis. And so I would give Rituxan and prednisone, theoretically, I guess cyclophosphamide, but I think Rituxan would be a good way to go.
Just to get back, the question of infectious related GN kept coming up. People in the chat box put, maybe get an echo. And, that's always a concern. I don't know if that was done here, but it's obviously always a concern. For what it's worth, the C3 was not there was no C3 in the biopsy, not that that's 100% either. And there are no polys in the biopsy, not that that's 100% either, but.
They're usually immune complex, aren't they? Even though they have vasculitis. I mean, there are. There's both actually, but. Well,
yeah.
Bartonella, there are case reports. I mean, we found one ourselves, right? There are case reports of these SBEs that can be Pauci immune, but they're unusual for sure, but they do occur. The thing that I was thinking about as this was being presented is my recollection, and Dr. Glassick knows this literature better than I do, but my recollection is that IgA nephropathy is associated sometimes with upper airway malignancies. And I don't recall if they're crescentic or not. I guess they could be a crescentic IgA, but when he was talking about this laryngeal cancer, I kept wondering whether this would have IgA in it, not infection related, but whether it be related to upper airway involvement with the cancer that then led to an IgA kind of vasculitic lesion.
Yeah, Steve, I think your recollections are correct. Upper airway malignancies have been associated with crescentic GN. The lower respiratory tract malignancies, lung cancer can be associated with crescentic GN, but frequently those are IgA
Yeah,
Did Crescentic.
which was negative in this case, but it was just
Right.
something that came to mind.
Casey, would you go Rituxan and steroids?
Yes. On the face of it, I would. I obviously, every patient is kind of a global assessment of where they are and if, how sick is the guy and, am I going to cause more problems by immunosuppressing him? But barring all of that, I mean, if I'm just looking at the biopsy and knowing his history, not knowing how sick he is, I would treat with prednisone and Rituxan.
The thing that surprises me the most about this case is the lack of chronicity, given that several months ago he was 2.4 and then he comes back in 2 months, after the first biopsy, he's 2.4, he comes back in, gets a biopsy, his creatinine's 4. Obviously, this has been going on the whole time. So, yeah, I think it's a very reasonable thing to try to treat him. Yeah, of course, as was brought up in the chat, we have to run this by our oncology, see how they feel about it. But for the big picture, but I was really surprised that we didn't see a dead kidney, quite frankly. Bill, you want to tell us what you did?
Yeah, we first reached out to oncology, and they were really moving towards a palliative type of chemotherapy. His head and neck cancer was progressing. And so that begged the question, really, what to do here. They weren't really planning on giving him more of the immune therapy. They were going to be doing local radiation. But he was about to either, die within a couple of days or go on dialysis, which would not be the best thing if we're moving towards palliative chemotherapy. So what we agreed to electively do is give him Rituxan, and we did lower dose steroids, actually, sort of like the Pexavast trial. We did 60 for the first week or so, but then we lowered it down. And we were focused on his comfort of life, but his creatinine actually came back down to 2, and his BUN came back down to 40 with that. And we gave him 4 different 375 per meter squared doses of Rituxan, over 4 weeks. And so he is still on palliative chemotherapy, still on palliative radiation therapy, and he's not on dialysis. So he's been going around 8 months or so, or 8 to 12 months range since the time of this diagnosis. And so we were able to actually give him a little bit of good quality of life still by keeping him off of dialysis, by treating him. Now, it also is possible that it was really ATN getting better and we were just treating ourselves, but he did have interstitial nephritis, he did have the podocytopathy, and he had the vasculitis, and many of his parameters have been better, not just the renal function. His proteinuria is also better too. So, this kind of begs the question that was really discussed well by everybody, that is this the cancer that was doing it, the ping, as Dr. Riemann even brought up in the chat, or is it related to chemo and the immune checkpoint inhibitor side effects? And there's really no way for me to tease it out, because the interstitial nephritis was there, like Dr. Gashi said. I was going to delve into the side effects from chemo-related therapies a little bit more, even though we're not sure if it was the immune therapy or not. I tend to believe it was. But again, somebody could say that it was cancer related too. And actually, I stole many of these slides from our onconephrologist, Dr. Gashti. So, it's kind of splitting these anti-cancer agents into 3 big buckets. And what our patient got was the epidermal growth factor receptor inhibitor, which eventually does inhibit tyrosine kinase as well. And he also ended up getting a PD-1 inhibitor. And so we typically see tubular interstitial disease with all of these, but I want to talk about their mechanisms just briefly. The checkpoint inhibitors allow you to not have your checkpoints anymore, and so that you basically have a T cell storm, which comes and crashes into the tumor. And so the side effects from that are really related to itis, inflammatory reaction everywhere. The epidermal growth factor inhibitors here can be done with a monoclonal antibody, which is what he got, or through the MIBs, which are direct tyrosine kinase, and those basically accentuate programmed cell death and just kill the tumor directly. And so that's kind of the mechanisms of the diseases of these agents. So this is the one that he got, and so that the epidermal growth factor was there, and then he got nivolumab for this PD-1 inhibitor. So wait, I may have skipped ahead, sorry. There's a little bit of a lag here. Okay. Yeah. So, you know, which one was it? Cancer? Maybe was it the EGFR? Which the funniest thing when I first heard out that these were called EGFR, one of the residents told me, "Oh, it may be related to somebody else was on an EGFR," and I said, who would name something an EGFR inhibitor that has kidney side effects? I mean, they could not have named that. And I told them that they must have been wrong on the acronym, because how in the world could you have a EGFR inhibitor that has kidney side effects? But no, in fact, they are. And this doesn't refer to estimated glomerular filtration rate, but of course refers to the epidermal growth factor. So there's not many case reports of glomerular disease. There's a lot more of the vascular disease that we talked about, but there are some reports out there of the drug that he got with vasculitis, actually, and one of them was even an ANCA negative vasculitis that was reported in 2009 with one of the EGFR inhibitors, and so that kind of goes along the possibility that it might have been his monoclonal antibody that was doing it. Could it have been his checkpoint inhibitor? Well, again, like you had said, itises were everywhere. But there are some glomerular diseases associated with the checkpoint inhibitors as well. And this was a nice review, which actually somebody put in the chat, who one of our previous fellows, Dr. Wadwani, was an author on this, where they looked at basically all of the different checkpoint inhibitor associated glomerular disease. So it separated out all the interstitial nephritis and the tube interstitial disease, but what was the overall literature showing us with checkpoint inhibitor glomerular disease? And most of them were posse immune vasculitis. And then the next biggest box was podocytopathies. And so our patient really fit well into this and his interstitial nephritis. And then the remission rates were variable depending on cessation of the offending agent and so on. And so delving into this just a little bit further, we actually found that the checkpoint inhibitors in this case series, where there were 4 of them, actually had posse immune vasculitis as well. And of the 4, all 4 of them were actually ANCA negative as well. And so this might fit with the checkpoint inhibitor renal vasculitis too. So we decided to give him Rituxan, like I said, and he had a bit of a renal recovery and was able to stay off of dialysis, which I think was a really, really important for his quality of life.
You know, the checkpoint inhibitor-induced interstitial nephritis is not a contraindication to redosing, and they just typically, ironically, you know, you'd think it would be an absolute contraindication, but it's not. They'll often give another dose at a lower dose, and you know, clearly we probably have no idea about the GN thing. This was a pretty bad reaction, but the point is that when people get a autoimmune reaction from an itis from a checkpoint inhibitor, it doesn't mean that they're absolutely contraindicated again. And you'd wonder if that's the case here. Do you know if oncology plans on repeating it at a lower dose or anything?
They would have if they had thought that there was going to be some efficacy with him, but since he's just doing palliative right now, they decided not to. But yes, they have no problem re-challenging with checkpoint inhibitors after they have initially been given, even if there's a immune-related side effect.
Yeah, I really like the question, which of course we don't have an answer about. Is this just malignancies? You know, it's kind of like when I think of interstitial nephritis. People that are on PPIs are much more likely to interstitial nephritis from a checkpoint inhibitor. And the way I think of it in my mind is that PPIs are very allergic and they just want to give you interstitial nephritis, but they don't until you get the checkpoint inhibitor, which brings it out. And the analogy here would be that, you know, malignancies, you know, there's something about them that want to give you a vasculitis, and the checkpoint inhibitor brings it out. That may be folly. I don't know. Who's showing this?
I'm showing it. Dr. Ream had said this in the chat, and I thought it was a really nice, very recent, ANCA negative happens in about 3% of patients with posse immune necrotizing GN that they're calling PING. And a lot of them are associated with malignancy. And there's a little section here on malignancy associated that 6 of the patients had ANCA negative. And that's without necessarily having a checkpoint inhibitor. So we really don't know, is the bottom line, is the malignancy itself, is it the CPI? And so it's a tough call, I think.
Yeah, well, it's a great case. Anybody have any other comments? Dr. Glassick?
Nope.
Great. Well, let's wrap it up. Thanks, everybody. Good luck to your brackets. Have a happy and safe St. Patrick's Day. And we'll plan on seeing everybody next week.